Hello, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this program regarding gait disturbance and assistive devices. This program is brought to you by EZQMECE.com, your one-stop provider for QME continuing education programs that are easy, convenient, and affordable. This program on gait disturbance and assistive devices is approved by the Division of Workers' Compensation Medical Unit for 1.5 to 3 hours of QME continuing education credit. And this program is available in several different formats. It's available as a written article format, which is a 19-page article, and this format is approved for 1.5 hours of continuing education credit. It's also available as an audio program, which it's possible that that's what you're listening to right now. The audio program is approved for 3 hours of continuing education credit. It's also available as a computer-based or web-based program, which is a PowerPoint presentation, which comes with audio narration. And if you're hearing my voice now, it's possible that you're either participating in the audio program or the computer-based program. And the computer-based program also is approved for 3 hours of continuing education credit. And the written article format, if you choose the written article, consists of a 17-page article. And like the other formats, it comes with a 10-question multiple-choice examination, which if you complete the 10-question multiple-choice examination with at least 7 questions correct, you will get a certificate of completion that documents 1.5 hours of continuing education credit. The audio program comes with 2 CDs, and it's approximately 2 hours and 35 to 40 minutes of audio material in compressed files, compressed into 2 CDs. Comes also with a 34-page reference book and has the same 10-question multiple choice examination. And again, if you complete those questions with 70% or better correct, you'll get a certificate of completion for 3 hours of continuing education credit. The computer-based program, the PowerPoint presentation, consists of 106 PowerPoint slides with narration. And I print out all the PowerPoint slides for you so that you can refer to those without having to be at your computer. Also comes with the examination and a certificate of completion for 3 hours of continuing education credit. And we provide these programs in 3 different formats so that you can choose the program that's the best for you. Some doctors like to read, and so we provide the program in a written article format. That's a convenient format because you can take the article with you wherever you go. If you're on vacation, or if you want to put it by your bedside, for example, like I do, you can read the written article format wherever you are. Some doctors prefer the audio program. I really like audio programs because they're completely portable, and our audio programs are recorded in the .AAC file format, so you can play those CDs in your car. You can upload those files into your iTunes. You can put the files on your MP3 player or on your smartphone, and you can take the program with you wherever you go and listen to it whenever you want. And some doctors like computer-based programs, and so we have a PowerPoint presentation that can be taken right at the comfort of your desktop. So we provide several different formats, and you can choose the one that works best for you. Before we get into our program today, I'd like to handle a couple of things. First of all, I want to introduce myself. My name is Perry Carpenter. I'm a chiropractor. I've been in private practice for over 25 years. I'm a graduate of Palmer West College of Chiropractic. I'm also a qualified medical evaluator, and I've been doing qualified medical evaluations since 1995. I'm a board certified chiropractic orthopedist. I'm board eligible chiropractic neurology, meaning that I have not yet taken the board certification examination, but that's one of my goals in the very near future. I'm also a certified chiropractic sports physician, a certified chiropractic extremity practitioner. I'm a certified strength and conditioning specialist, which is a non-chiropractic credential. That's a credential through the National Strength and Conditioning Association. I'm also assistant adjunct professor of anatomy and physiology at Los Rios Community College District, which is in the Sacramento, California region. This program and additional programs are being brought to you by easyqmece.com. That's a website where you can review all of our continuing education programs, and we have several. And the purpose of easyqmece.com is to bring you programs that are convenient, that are low cost, and that are easy. They're easy to take. They're easy to take because they can be done on your own time, at your own location. You don't have to travel to a seminar program. EasyQMECE.com offers distant learning programs in 3 formats that I explained earlier. You can get programs as written articles. You can get audio programs. You can get web-based programs. And those can all be completed in the comfort of your own home, your own office, and on your own timing. So before we get into today's program on gait disturbance, I'd like to share with you a couple of additional programs that are available for QME continuing education. We have a program called Medical Legal Report Writing and Technique of the QME Examination. This is a great program. This is a 6-hour program. This is approved for 6 hours of continuing education credit. Like all of our programs, it's available as a written article. It's available as an audio program, and this audio program is 6 hours of recorded audio, which is on 7 CDs, spills over onto a 7th CD, so it's just a hair longer than 6 hours. It's also available as a computer-based PowerPoint program, and I'd like to share some of the topics with you so that you will be interested in ordering this program as well, either now for your next recertification deadline, or perhaps for the one that follows. The Medical Legal Report Writing and Technique program begins with Section 1, which goes over several topics related to medical legal report writing. And right away we get into the topic of substantial medical evidence. And we talk about what actually qualifies as substantial medical evidence. And I give you some language that you can import into your own QME reports to make your reports qualify as substantial medical evidence. You'll find that very valuable. We go into the required elements of QME reports as is described in the 2001 Physician's Guide. You might be thinking, the 2001 Physician's Guide, what are you talking about? Well, even though most cases that we're seeing now fall under the AMA Guide's 5th edition, we still are seeing injured workers with dates of injury prior to 1105 that are required to be reported upon using the 1997 Permanent Disability Rating Schedule. So a review of the required elements of those earlier dates of injury is still valuable, and some of those required elements still apply to dates of injury after 1105, and explain how and why the Physician's Guide is still useful and valuable even for dates of injury after 1105. So that's a valuable discussion. We then go into QME reports and the required elements of now the permanent impairment evaluation, not the permanent disability evaluation, but now the permanent impairment evaluation, as that's described in AMA Guide's 5th edition. And then we assemble the required elements from both of those reports, or both of those guidelines, the 2001 Physician's Guide and the AMA Guide's 5th edition, and we come up with a sort of a hybrid format that includes the best qualities and the best elements of both styles of report to come up with a hybrid format that includes required elements for all dates of injury. And it's a report writing format that you can use regardless of the date of injury. And I provide that format to you in this program. Section 2 then goes into the QME panel process and talks about how QME panels are selected and when and why QME panels are generated and how it is that your name can end up on a QME panel. We go over the labor codes that govern the QME panel process, and I explain the different types and situations of QME examinations that come up. We go over the $10,000 rule, which is Labor Code 5402. We go into issues of disputed liability under Labor Code 4060. We go into issues regarding disputed permanent impairment under 4061. And then under Labor Code 4062, we go over all other issues of dispute for both represented and unrepresented workers. And then finally, we finish this section with a discussion or a determination as to whether you are the panel QME rendering this examination, whether you are the AME rendering this examination, or possibly are you the agreed panel QME rendering the examination. And this relates to cases where injured workers are represented, and I give you a procedure and a process to determine what actually is your role. Are you the QME, the AME, or the AP QME? And I know you'll find that valuable as well. In Section 3 of this program, we start to get a little bit clinical, and the doctors will find this a valuable review. We talk about technique of the QME examination, and we go over several procedures to improve the quality of your QME examination process. And I give you several suggestions on how to make mental notes in your observation of the examinee. We go into a brief discussion of gait analysis and assistive devices, and I say brief because gait analysis and assistive devices and those topics are discussed in full detail in the current program that we're about to get into in a few minutes. But we touch upon some of the basic concepts and brief concepts here in this program, the Medical Legal Report Writing Technique program. We go into some effective communication skills for the doctor to help ensure that your injured worker is comfortable with you and that you can have rapport, so that you can have rapport and honesty and open communication during the evaluation. And then we go into some practical methods for obtaining the history and the relevant medical history sections of your QME report. And those are done in the face-to-face meeting with the injured worker. So I give you some practical suggestions for obtaining accurate history, current history, and accurate relevant medical histories. We then continue with more technique regarding the examination, and we go into a discussion of the importance of the neurologic portion of the examination because of the heavy emphasis on the neurologic examination in the AMA guides. And many chapters stress the importance of the neurologic examination, whether that involve an examination of a spinal injury, an upper extremity injury, lower extremity injury, a central nervous system injury. And so we begin that discussion with a brief review of neuroanatomy, at least as it involves the QME examination. We talk about the components of the neurologic exam by body region, and that's a great review. Finally, we finish with a discussion of the tools and the instruments that are required for the neurologic examination. And I know that many doctors have all of the required neurologic tools and instruments, and some doctors do not. So I give you a review of all the tools and instruments that should be in your bag, your doctor's bag, and I give you references as to where you can obtain those instruments quickly and inexpensively if you don't already have those. We have also another program available. This is a 3-hour program. It's called the Non-Physiologic Examination, and this is a fascinating program. This is a valuable program, and I recommend all doctors to get this program because it will refresh your memory as to concepts relating to consistency during the physical examination, and it will give you several different insights that will help you when it comes time to render your opinions on permanent impairment and causation/apportionment of the permanent impairment. And this is quite a valuable program. Also comes as a written article. The written article is a slightly longer article. It qualifies for 2 hours of continuing education. It comes also as an audio-based program, just like all the other programs. It qualifies for 3 hours of continuing education. Also comes as a computer-based program, and that also qualifies for 3 hours of continuing education. The written article is a 19-page article, comes with a 15-question multiple-choice exam and a certificate of completion. The audio program is 3 audio CDs, comes with a 27-page reference book. The computer-based program consists of 81 PowerPoint slides with narration, comes with a printout of the PowerPoint slides so you can use those or read those wherever you are or wherever you go, and also comes with the examination and the certificate of completion. Again, you can choose the format that's best for you. And a real quick discussion of the topics of the non-physiologic examination program begins with a discussion of practical considerations for the quantification of pain. And by that, we're talking about how is it, we answer the question, how can you describe the pain that another person describes to you? Since we cannot feel pain and we cannot see pain and we cannot experience the pain that another person is experiencing, how can we describe or quantify their descriptions of pain into a language that's usable in the workers' compensation system? And so this is a valuable discussion that will help you when it comes time to render your opinions on permanent impairment and sort of make a determination as to how the industrial injury impacts the ability to complete daily living activities. It sort of allows the doctor to translate what it is that the injured worker is telling you into a language that can be used in the workers' compensation system. We go over activities of daily living assessments, and I actually go through a mock injured worker evaluation where I go through an activities of daily living assessment so that you can see how it is that we take the material that we learned in Section A on practical considerations and apply it to the activities of daily living assessment. And you'll find that to be useful and fascinating. We go into discussions of malingering, talk about the Waddell's signs of inconsistency, and we define malingering as it's defined in the Diagnostic and Statistical Manual of Mental Disorders. Finally, we go over how to review medical records and how to compare the findings of the medical records with the findings during the QME interview process, and how to locate possible inconsistencies there. And then we transition from the interview into the physical examination, and we look for areas of inconsistency between those three sources of information: the medical records, the interview, and the physical examination. And you'll find that to be a valuable discussion, and that'll make your very next QME examination a completely different type of examination if you implement the material from that topic. Now let's get into today's discussion. We're talking now about gait disturbance and assistive devices, which is an important consideration and becoming increasingly important now in the era of Alvarez-Guzman II. We go into the strict descriptions of gait disturbances and gait disorders as those are described in the AMA guides. Descriptions of gait disturbances are found in chapters 13 and chapter 17 of the AMA guides, and we go over the permanent impairments due to gait disturbance under the strict application of the AMA guides, strictly as those are described in chapters 13 and chapter 17. Then we go over a description and a procedure that you can use for the gait analysis, and I give you several different observations that you will use in determining if there actually is the presence of a bona fide gait disorder. We then go into the descriptions of the phases of normal gait and pathologic gait. We break down the gait cycle into several different sub-phases of gait, and we talk about normal findings in each of those sub-phases, and then we describe possible abnormalities of those sub-phases that would be present in the presence of pathologic conditions. Then we talk about the causes of deviations from normal gait. In other words, if you do actually find a gait disturbance in your injured worker, what could be the cause of those deviations? I give you several different types of problems that can cause abnormal gait. We then go into a discussion of the named gait signs, and some of those will sound familiar to you and some of those will be new. We then move into a discussion of assistive devices, because the AMA guides talk quite a bit about assistive devices and the need for assistive devices in the permanent impairment determination. So we go into a discussion of canes, we talk about crutches, we talk about pickup frames, we talk about ankle-foot orthoses and knee-ankle-foot orthoses, and in particular we give special emphasis to discussion of canes, because more and more injured workers are coming to QME examinations with a cane. We talk about proper use, we talk about how to inspect a cane, we talk about the proper fit of a cane, and you'll find that to be a valuable discussion in your determination as to whether or not the cane qualifies as a medically necessary device under the workers' compensation system. And then finally the chapter concludes, or the program concludes, with a couple of final basic considerations. Okay, so let's begin with a couple of general considerations now. Let's talk about what is gait. You've heard the term of gait, and the AMA guides refers to gait disturbances. What actually is gait? Well, Let's go to Webster's dictionary. Webster gives us three different visual mental images and descriptions of what gait is. Webster says, number one, that gait is a manner. It's a manner of walking or moving on foot. Number two, gait is a sequence of foot movements, such as in a walk, a trot, a pace, or a canter, by which a horse or a dog moves forward. And number three, Webster says that gait is a manner or rate of movement or progress. So let's think about this. Of course, in workers' compensation, when we discuss gait, we're referring to the manner in which injured workers, rather than dogs or horses, progress forwards by means of walking. And human beings, just like dogs and horses, have a normal gait. And so, without much further analysis, if we review Webster's dictionary and Webster's definition, he gives us some indication as to what a normal gait would look like, and then, therefore, what an abnormal gait would look like. So, for example, in referring strictly to the definition as it's given to us by Webster's dictionary, a normal gait would be a smooth manner of walking or moving on foot. It would be a balanced sequence of foot movements. It would be an unlabored manner or rate of movement or progress. So, and that makes sense, and you can picture that in your mind and apply that to your own gait as you walk or move on foot. You move smoothly. You move in a balanced fashion with your weight evenly distributed on both feet. It's an effortless or unlabored rate of movement in the normal situation. Well, it would be then therefore easy to describe what an abnormal gait would be. It would be a disrupted manner of walking or moving on foot. It would be an unbalanced sequence of foot movements where weight is shifted more to one side and off of a dysfunctional or a painful side. It would be a labored or a difficult manner or rate of movement or progress, and you can picture those descriptions in your mind, especially the last one, a difficult manner. Gait should be effortless with a coordination of upper body and lower body movements, and anytime we see a disruption of the coordination or the manner becomes labored or difficult, we could suspect a gait disturbance. Now, this sounds simple enough, and simple it is, really, because like honesty and love, while what qualifies as normal and abnormal gait may be difficult to describe, it's easy to spot when it's present, right? Might be a little difficult to actually describe what qualifies as honesty or love, but you know when it's there, and you know when it's not. And the same applies to gait. You can tell, if you observe carefully, you can tell quite quickly whether or not the gait is normal or abnormal. And as qualified medical evaluators, the gait analysis can be the very first assessment made in the evaluation process. And unlike range of motion and neurologic tests, the gait analysis can be done informally and can be done by casual observation. And I recommend that the gait analysis be done at the very beginning of the QME evaluation, and I go into a description of the process by which you can do a gait analysis a little bit later on in this article. Let's get into Chapter 13 of the AMA Guides, where gait disturbances are discussed, and specifically I'm referring to Table 1315. This is the nervous system chapter, where impairments due to loss of balance and unsteady gait due to central and peripheral nervous system disorders is described. And this is Table 1315, so let's go through these definitions one by one. The first level of impairment described in Chapter 13 due to gait disturbance is a Class 1 impairment, and this describes an injured worker who rises to a standing position. Okay, so that's obviously from a seated position or a lying position. He rises to a standing position, he walks, but he or she has some difficulty with elevations, with grades, with stairs, with deep chairs, and long distances. So this describes a minimal impairment, but it's a person who would have some labor with walking long distance, would have a disrupted manner of going up and down stairs. And what would be a normal manner of going up and down stairs? Picture that in your mind. This person would have a disrupted manner in going up or down stairs. They would have a labored manner of handling elevations and grades, and so you can picture this in your mind. The next level of impairment is Class 2 impairment. This is a person who again is able to rise to a standing position, is able to walk some distance, but now with difficulty, a little more difficulty, but is able to walk without assistance, but is mostly limited to level surfaces. Okay, so this is a person who now cannot handle stairs, cannot handle grades, and cannot handle elevations. So a significantly higher level of impaired function of gait. The next level of impairment described in Table 1315 is a person who rises and maintains a standing position with difficulty, and cannot walk without assistance. So picture that in your mind. This is a person basically who can just barely stand, So they might need assistance, for example, to get up and out of a chair, and assistance either by pulling themselves up, by using an assistive device, or by getting the help from a nearby person, and then cannot walk without assistance. In other words, they require assistance for walking, whether that be assistance from an assistive device such as crutches, a walker, or help from an assistant person. So a significantly higher level of impairment. And the highest level of impairment is a Class 4 impairment. This is a person who cannot stand without help, cannot stand without mechanical support or an assistive device. Basically, this is a person who cannot stand. If you take away the crutches, if you take away the walker, if you take away the supportive person, this person cannot stand. So they're relegated to simply sitting or lying down due to dysfunction of the lower extremities or some other central or peripheral nervous system disorder. Now, central to these disturbances in gait is an underlying neurologic disorder. Okay, Chapter 13 is about the nervous system. So that neurologic disorder can be due to injury to the central nervous system, for example, as would occur with a traumatic brain injury, such as would occur with a stroke, such as would occur with multiple sclerosis, for example. Or it could also be due to disorder of the peripheral nervous system. And examples of disorder of the peripheral nervous system would include conditions such as peripheral neuropathy, perhaps diabetic neuropathy, alcoholic neuropathy, or even traumatic injury to peripheral nerves. Now, a Class 1 impairment qualifies as a 1 to 9% whole person impairment. Class 2 impairment qualifies for 10 to 19% whole person impairment. Class 3 impairment qualifies for 20 to 39% whole person impairment. And Class 4 impairment qualifies for 40 to 60% whole person impairment. Now, in observation of your injured worker, the separation between Class 1 and Class 2 impairments and Class 3 and Class 4 impairments is easy to identify because the higher impairments, the Class 3 and Class 4 impairments, those involve an assistive device. The Class 1 and Class 2 impairments are a little more difficult to classify because typically we don't have the opportunity to go outside the examination office and actually observe our examinee to walk up elevations, to walk up grades, to walk up stairs, or to walk for distances, right? We don't really get the chance to do that. We have to take that upon their subjective report. However, in casual observation of the injured worker, the Class 1 and Class 2 impairments would manifest with several findings, several observable findings. For example, you might notice a loss of equal arm or leg movement. Right? That would be a labored manner of walking. We might see falling or staggering to one or the other side. We might see the inability to control starting or stopping of the movement. We might see arrhythmic body or extremity movements. And these findings would be almost exactly consistent with our modified Webster's dictionary definition of a disrupted manner of walking or moving on foot, an unbalanced sequence of foot movements, and a labored or difficult manner or rate of progress. And this is easy to spot for QME who is observant in checking for these things. Okay, let's go into Chapter 17 and see what Chapter 17 says about gait disturbances. Now, unlike Chapter 13, in Chapter 17, when we see a gait disturbance, that gait disturbance is due to a limp, due to some type of a lower extremity injury. So not necessarily due to a central or peripheral nervous system injury, but now is due to some sort of a condition in the lower extremity. So Table 17.5 of the AMA Guides talks about the various levels of impairments that we may see. First is a mild impairment, and with a mild impairment we have an antalgic limp. And I go into a description of what an antalgic limp is a little bit later on in this program. But we see an antalgic limp, and we see a shortened stance phase. And I describe the stance phase and the other phases of gait also shortly here. Now, in addition to an antalgic limp and a shortened stance phase, those are subjective findings that are subject to the influence of the examinee. In addition to those subjective findings, we also see the presence of objective findings. We have documented moderate to advanced arthritic changes of the hip, knee, or ankle of the lower extremity joints. Now note here that this description of mild impairment, it discusses moderate to advanced arthritic changes. That's not early to moderate advanced degenerative changes. It's moderate to advanced. So substantial objective findings to corroborate the subjective findings of an antalgic limp with a shortened stance phase. We could also see, for example, a positive Trendelenburg sign. And I describe a Trendelenburg sign and a Trendelenburg gait here shortly also. And again, the positive Trendelenburg sign, that's a subjective finding. That is subject to the considerations or factors going on within the injured worker and qualifies as a subjective finding because a Trendelenburg sign and any other gait disturbance or limp can be exaggerated, can be fabricated. And in order to qualify for permanent impairment under Chapter 17, Table 17.5, there must be also associated documented objective findings. So in this case, there must be documented advanced osteoarthritis of the hip. Excuse me. Documented objective findings. And then also another mild impairment would be the same as number 1 or number 2 above, but now the individual requires part-time use of a cane or crutch for distance walking, but usually not at home or in the workplace. So you can see that the mild impairments could include both the presence or absence of an assistive device. An assistive device in this case, in this example, is not required to qualify as a mild impairment, but when present, an assistive device could qualify for mild impairment under this description. Finally, this person could require the use of a short leg brace. The use of a short leg brace and ankle-foot orthosis could also qualify as a mild impairment. Okay, the next higher levels of impairment described due to lower extremity injury would be the moderate impairments. Moderate impairments would involve the routine use of a cane, routine use of a crutch, or a short leg brace and ankle-foot orthosis, or routine use of a long leg brace and knee ankle-foot orthosis. This is described as the KFO orthosis. Or if you have an injured worker that requires the routine use of 2 canes or 2 crutches. And now picture this in your mind. This is a much more substantial level of impairment if you have a person who comes to you with 2 canes. And I describe canes later on in this program. And picture in your mind the forearm canes. Forearm canes where there's a bracket that goes around the mid portion of the forearm, and you've seen these people in the public that sort of advance by placing the forearm canes out in front of them to relieve weight bearing from the legs, and then the legs follow and catch up behind the forearm canes. And you've seen these people, a substantially higher level of impairment. And this will be easy to determine because the presence of the assistive device would be quite obvious. Okay, and then the severe impairments would be a person who requires routine use of 2 canes or 2 crutches and a short leg brace, routine use of 2 canes or 2 crutches and a long leg brace, and a person who requires routine use of 2 canes, 2 crutches, and now 2 lower extremity braces. And now, for example, picture this in your mind. An injured worker comes to you with a short leg brace on one leg, a knee ankle foot brace on the other leg, and in addition to those assistive devices, presents to you also with 2 canes or 2 crutches. Okay, this type of person is going to be easy to spot coming because they're going to have quite a labored and unbalanced sequence of movements, and of course they'll be carrying assistive devices, so you'll spot those. Or a person could be wheelchair dependent. That would also qualify for a severe impairment. Now, central to these disturbances in gait, whether they be mild, moderate, or severely impaired with gait, is a primary disorder not in the central or peripheral nervous system, but now in the lower extremity joints, such as the hip joints, the knee joints, the ankle joints, or in the feet. And in observation of such a person, the separation between the mild impairments and the moderate and severe impairments is the presence or the absence of an assistive device. Now, make note of this. The mild impairments that do not require an assistive device, which was the antalgic limp with shortened stance phase, or the positive Trendelenburg sign, those are a little more difficult to classify because they require more than an observation of whether or not an assistive device is present, they require an actual observation of the gait. They require you to actually observe the gait. So you don't have to observe the gait in a person who presents with 2 crutches and 2 canes. Okay, you can see that the assistive device is present, and they qualify for impairment simply by the dependence upon the assistive device. But it's the lower level impairments, the mild impairments, that require you to actually observe the gait. And these 2 major types of gait or derangement, the antalgic limp with a shortened stance phase and the Trendelenburg gait, those are exactly consistent with our modified definition, which is a disrupted manner of walking, an unbalanced sequence of foot movements, and a labored or difficult manner or rate of movement or progress. And this is easy to spot for the QME who makes the gait analysis a deliberate part of the evaluation process. And I go over some suggested methods for conducting the gait evaluation in our next section. Okay, so let's talk about some practical methods for conducting a gait analysis. The gait analysis begins even before meeting the injured worker. And the gait analysis begins with your preparation, and I offer some suggestions here that will help you organize your procedures to allow for an effective analysis of the gait. Now, your preparation for the gait analysis begins even before you meet the injured worker. And for any type of a spine injury, any type of a lower extremity or neurologic injury, and even in the case of an upper extremity injury, you should be prepared in advance to evaluate the gait. Now, a gait analysis will not always be required for an upper extremity injury, such as a shoulder injury, for example. But because of the growing use of analogous impairment due to gait disturbance under Alvarez-Guzman 2, be prepared to do a gait analysis on more cases, even if initially the applicability of the gait analysis doesn't really seem to make sense, because more and more cases are requiring a discussion of analogy to gait disturbance under Alvarez-Guzman 2, even in upper extremity cases, and I give you some examples later on in this program. So it's better to be over-prepared and to over-examine your injured worker than it is to miss an important finding and not be able to return later to capture it. So be prepared in advance to do a gait analysis on most, if not all of your injured workers. So when it comes time to meet the injured worker for the first time, have the gait analysis on the top of your mind. This is when I like to put my video camera in my pocket. And the following procedure that we'll go over is a procedure that I've developed over the years to obtain the gait analysis in a practical manner that's quick and that provides a lot of information. And we're going to break down the gait analysis procedure into 5 simple steps. First is the observation. Second is the interrogation. Number 3 is the definition or the defining of the gait disturbance if there is one present. Number 4 is a videotaping of the gait disturbance. And then step number 5 is the review of videotaping to evaluate that gait disturbance for consistency with other findings throughout the history and throughout the physical examination. So let's go over these here now one by one. In the observation of the injured worker, this begins the minute that you meet the injured worker for the first time. So your injured worker is going to be out in the waiting room. And as you come out to meet and greet the injured worker, you're going to observe for the presence or the absence of assistive devices. Now, large assistive devices such as crutches, canes, a cane, a wheelie frame, or a wheelchair, certainly those are going to be immediately obvious. But less obvious are small supports or small braces that could be hidden by clothing or that just escape your attention because of their size. Observe the manner by which the injured worker rises from the waiting room chair. Does the injured worker rise by pushing off their legs with their hands? If so, this is known as a positive minor sign. Do they rely heavily on the arms of the chair to push against? If so, this is a positive finding. Again, that would be another example of a positive minor sign. And minor sign, or this maneuver of pushing off the legs with the hands, that's used in an effort to spare lower back and lower extremity effort, and it's present in many lower back and lower extremity pathologies. And when this positive minor sign is present, it could be a sign consistent with a Class 1 impairment in Chapter 13, which recall stated that the person rises to a standing position, walks, but has difficulty with elevations, grades, stairs, deep chairs, and long distance. So difficulty with rising out of a deep chair, that would be manifest as a positive minor sign. That could qualify for a Class 1 impairment, or could qualify for a Class 3 impairment due to, and here's the definition of a Class 3 impairment, rises and maintains standing position with difficulty. So you observe your injured worker to rise from the waiting room chair, and you make an assessment as to how difficult that is. Is there the presence or the absence of a minor sign? And you assess that, and you think in your mind whether that could qualify as a Class 1 or a Class 3 impairment. Then what you do is, what I recommend that you do is you invite the injured worker to come back to the examination room, and you observe their movement from the waiting room to the examination room. And as they follow you to the examination room, what I do is I walk in front of them. But I walk backwards so that I can observe their gait. And I walk down the hallway to the examination room backwards while they walk with me forwards, and I observe their gait. Now, if there's no noticeable gait disturbance, in other words, you don't see any type of a shortened stance phase, you don't see any type of an antalgic gait, there's no sort of a Trendelenburg sign, I always question the injured worker, and I ask him, can you walk okay? Do you have any kind of limp? Do you have any kind of pain with walking? And I interrogate them about their gait. Sometimes they think I'm crazy, but I go through this with all lower extremity injuries, certainly, all spinal injuries, certainly, and even upper extremity cases as well. Now, if they answer in the negative, in other words, they say, no, I don't have any type of gait disturbance or problem, then basically the gait analysis is over. I mean, there is no further gait analysis. And then we simply proceed back to the examination room. If there is some kind of a noticeable gait disturbance, I question them and I ask them the same questions. I ask them, can you walk okay? Do you have a limp, or do you have any kind of pain with walking? And I confirm with them that what I'm seeing is actually a gait disturbance, and it's not simply some kind of compensation perhaps for a poorly fitting shoe, for a stubbed toe, or for something else that does not qualify as a gait disturbance. And if I do detect some noticeable type of a gait disturbance, and the injured worker confirms that yes, indeed, they do have a limp, or pain with walking, then that begins the formal gait analysis. And I immediately take the injured worker outside the building to a parking lot or to a long sidewalk, and we go through the formal gait analysis. And there's several steps involved with the formal gait analysis. And what you want to do is you want to observe the gait from at least 3 positions, and you want to be able to observe the gait over a substantial distance so that you can determine the consistency of the gait finding, and you can define the gait finding, and that requires a considerable distance where the injured worker is allowed to take several steps, at least 10 to 15 steps, so that you can detect and identify the pattern. So I observe the gait from at least 3 positions, from the front, from the back, and from the involved side. And for the purposes of this discussion, let's just consider that the involved side would be the left side. So for example, I would have the injured worker walk 20 yards towards me as I observe the gait from the front of the examinee. I would have the injured worker walk 20 yards away from me as I observe their gait from the examinee back. I would have the injured worker walk 20 yards while I observe the gait from the side of the affected limb. And the next step, once you identify some type of a gait disturbance or some type of labored or unbalanced movement, the next step is to define and characterize the observed disturbance with help from the injured worker. And I always ask the injured worker for their help to characterize what the problem is. I ask the injured worker to define for me what it is in their opinion that's causing the disturbance in the gait, and exactly what is the disturbance. Now, many times the injured worker themselves will help you identify the cause of the gait disturbance, and you confirm that their description of the cause of the disturbance corresponds to what you are observing the disturbance to be. And for any type of a visually noticeable gait disturbance that the injured worker describes to you and that you are able to observe on an objective basis, I always recommend a videotaping of the gait. And this will be this will be valuable to you later when it comes time to write your report. And when describing any type of a gait disturbance in my report, and especially if I consider it to be a bona fide disturbance in gait, I always indicate that upon request, and this is a quote I put in my report, upon request, I can produce videotaping footage of the gait analysis at the request of the parties. Now, I've never been asked to produce this footage, but in my opinion, having videotape footage of a gait disturbance makes the report and the description of the gait disturbance more substantial, because as the old saying goes, a picture is worth 1,000 words, and if a picture is worth 1,000 words, a videotape is worth even more. So again, like the observation of the gait, I would videotape the gait disturbance again from 3 positions. I would videotape it from the front as the examinee walks towards me, and make sure that you allow 20 yards for this so that you can get a good repetitive pattern of the gait disturbance. Videotape also from the back, and then also videotape from the side of the affected extremity. When you get back to your office later, you're going to want to review this videotaping for consistency. Consistency meaning consistency with the history, consistency with the medical records. You're going to review your observed gait disturbance for consistency with known anatomy and physiology. And we'll get into a breakdown of the gait cycle here in just a minute. And you're also going to review the observed gait disturbance for consistency with your examination findings. And this is an important review, is a review for consistency. So just to review those steps, the gait analysis involves with observation, interrogation, definition, videotape, and review. So let's get into now a description of the phases of normal gait. And we're going to break down the gait cycle into several sub-phases and describe those sub-phases as they would appear in the presence of normal gait. And once we have an understanding of what normal gait looks like, then we can go into a description of what abnormal gait would look like. Now, the cycle of one limb, as it first touches the ground in front of the body, then 2 as it moves behind the body, and then number 3 as it comes back into contact with the ground again, this is known as the gait cycle. Now, to analyze the gait of your injured worker, you begin by looking at the beginning point of the cycle, at initial contact of the foot with the ground. Okay, you then follow the foot as it passes behind the body, and then you follow it forward until it contacts the ground again. This is one complete cycle. Now, this cycle has been broken down into the millisecond by researchers and kinesiologists, and that, of course, would be on that type of analysis would be on the scope of this program, and it's not necessary for the QME examination, however. But some detail about the phases of the gait cycle will make an analysis of normal and abnormal gaits easier and therefore more descriptive in your report writing. And so we're going to go over some of those phases here in this program. Now, the period of time when the foot is in contact with the ground, that's known as the stance phase. When the foot is in contact with the ground, that's known as the stance phase. The stance phase is the weight-bearing portion of the cycle. The stance phase, let me repeat that. The stance phase is the weight-bearing portion of the gait cycle for that foot. And in this case, we're talking about the left foot. Now, the period of time when the left foot is off the ground, that's known as the swing phase. And the swing phase is the non-weight-bearing portion of the cycle for that foot. Talking here again about the left foot. Now, throughout the gait cycle, 60% of the time is occupied with the stance phase, and 40% of the time is occupied with the swing phase. So 60% of the time is weight-bearing. 40% of the time is non-weight-bearing. And understanding this ratio, 60-40, makes it easy to detect what is described in the AMA guides as, quote, an antalgic limp with a shortened stance phase, unquote. Shortened stance phase. So with a shortened stance phase, or a shortened weight-bearing portion of the phase of gait, the ratio of 60-40 starts to change, and that 60 starts to become a smaller number. In fact, we might see a 50-50 type of ratio between the stance phase and the swing phase, or even less time involved with the weight-bearing phase. And this becomes quite easy to detect when it's present. Now, the stance phase can be further broken down into several sub-phases, including the heel strike phase, the mid-stance phase, and the push-off phase of gait. And because the stance phase occupies the majority of the gait cycle, we're going to take a look at each of these sub-phases in a little bit more detail. Then the swing phase, that comprises 40% of the gait cycle, and we'll get into some description of some normal and abnormal findings of the swing phase of gait as well. Okay, so let's talk about the heel strike phase of gait and findings that we would see in the presence of normal gait at heel strike and some possible deviations from the normal gait in the presence of pathologic conditions. Focusing all of our attention now on the heel strike phase of gait, and in this example we're again talking about the right foot. Yes, these examples that we're going to go through now discuss normal phases of gait with the right foot. Okay, so at heel strike, this begins with the initial contact of the heel on the ground. And if we focus our observation on the right lower extremity from a lateral view now, we find that in normal heel strike, the head and trunk are vertical. The right arm is slightly posterior to the midline of the body with the elbow slightly extended. And let's just think about this for a minute, doctors. With right heel strike, the right arm is slightly posterior to the midline of the body. So as the right leg comes forward, the right arm goes backwards. Well, as the right arm goes backwards, the left arm is slightly anterior to the midline of the body with the elbow slightly flexed. The right knee is extended, but's not locked, and the ankle is in slight plantar flexion. Now, take a moment to picture this image in your mind. Picture in your mind the image of a person walking normally and focus in on the heel strike phase. Okay? Head and trunk are vertical. The right arm is slightly back of the body. The left arm is slightly forward of the body. The right knee is extended, and the ankle is in slight plantar flexion. And that makes sense. As the heel strikes the ground, the ankle starts to move into slight plantar flexion. Now, in the presence of pathologic conditions, in other words, problems, injuries, trauma, some common observable deviations from the normal pattern that we might see would include a forward shifting of the head and trunk. In other words, the head getting ahead of the midline of the body. We could see that the right knee is locked in extension or hyperextension, or we could see that the knee is flexed and fails to achieve extension. We could see that the foot lands flat on the floor, or even that the toes land first on the floor. The forefoot and toes may slap the ground, and create a mental image picture of each one of these deviations. Picture an injured worker with his body ahead of his head and trunk ahead of the legs. Picture the knee partially flexed and failing to achieve full extension. Picture the toes landing first on the ground and slapping on the ground. I recommend this, visualizing these in your mind, because seeing them first in your mind makes it easier to identify these deviations in the physical world when and if they are present. So go through this exercise in your mind, and therefore the next time you see an injured worker with these deviations, you will have already seen them, and you'll instantly recognize those when they're present. Let's talk about heel strike now from an anterior view. What would it look like if we were to evaluate the injured worker, this time looking at them from the front? Well, again, focusing in on the right lower extremity, at heel strike, we find that the head and trunk are vertically aligned. We see that the arms swing at an equal and symmetric distance from the body. Now you're looking at the injured worker from the front, and he's walking towards you. So the arms should swing at an equal distance from the body. We see that the pelvis lists slightly inferior on the right side, on the weight-bearing side. We see that the right thigh and leg are in vertical alignment with the pelvis, and as the injured worker walks towards us, we see that the plantar surface of the foot is visible approximately 10 feet away from the examinee. As the examinee walks towards us, we start to be able to see the plantar surface of the foot. Now, in the presence of pathologic conditions, in other words, following injury or following trauma, we see some deviations from those normal findings. As the injured worker walks towards us again from an anterior view, we see that the trunk is displaced either to the right or to the left. And more common would be a leaning to the right towards the weight-bearing side. We could see that the right hip is in lateral rotation. We could see that the right hip is in protective abduction in order to broaden the base of support. So we would see that that right hip moves away from the right hip and leg moves away from the body to contribute to a broader base of support. And we could see, for example, that the plantar surface of the foot is not visible. That would be a sign of limited dorsiflexion of the foot. So take a moment to visualize some of these findings in your mind's eye. Okay, let's take a look now at the mid-stance phase of gait. This is the main weight-bearing portion of the stance phase, is the mid-stance phase of gait. Now at the mid-stance phase of gait, the body's center of gravity is now over the base of support. So looking at the right foot now from the lateral view, with the body's center of gravity over the base of support, we should see that the head and trunk are vertical. Both arms are near the midline of the body with the elbows slightly flexed. Of course, the elbows are going in opposite directions. One's coming forward and one's coming backwards, but they're meeting at the midline as they pass through opposite directions of motion. We see that the knee, the right knee, should be in slight flexion, and the right ankle is in slight dorsiflexion now, as the body moves over the base of support. In the presence of pathologic conditions, we see that the head and trunk now become shifted either forwards or backwards of the hip joint, so that the center of gravity becomes placed either forward or backwards of the base of support. We see that the knee is locked in either extension, hyperextension, or in a position of exaggerated flexion. You might see that the ankle is found to be in exaggerated dorsiflexion. Now, what about from the anterior view? From the anterior view, as the injured worker walks towards you, the head and trunk are vertical, and the arms are at an equal and symmetric distance from the body, and the pelvis possibly could list slightly now to the left side, and the right hip has a slight lateral rotation. And this is describing a specific type of gait, and I'll reveal that to you here shortly, but for now just picture this in your mind. Now, in the presence of pathologic conditions, the head and trunk tip to the right. Head and trunk tip to the right. The pelvis tilts upward on the left side with the right arm away from the body, or possibly the pelvis has an exaggerated list to the left side, to the opposite side. Other findings could include an exaggerated outward rotation of the hip and or varus or valgus positions of the foot. And just picture those in your mind, varus or valgus positions of the foot. Okay, so those are some findings in the mid-stance phase of gait. What about in the push-off phase of gait? Okay, so now the foot is moving behind the body. The heel rises from the ground. and the foot is just about getting ready to enter the swing phase of the gait. Well, again, looking at the right foot from the lateral view, in the presence of normal gait, we would see the right arm would be anterior to the midline of the body now, with the elbow partially flexed, and then we would see that the left arm is slightly posterior to the midline of the body, with the elbow extended. Pelvis has an anterior tilt. The right knee is partially flexed. The ankle is in plantar flexion now, and the toes are in extension at the metatarsal phalangeal joints as the body weight gets pushed off by the toes at the metatarsal phalangeal joints. In the presence of problems such as injury or trauma or pathologic conditions, we see that the arms would be an uneven distance from the midline of the body. We would see that both elbows are flexed. The pelvis has an exaggerated anterior tilt. Possibly the knee could be forcibly extended. The ankle plantar flexion may be limited, or the ankle may be in a position of dorsiflexion, and the metatarsal phalangeal joints may be neutral rather than in extension. And that would be common in problems with the foot, for example, pinning of the metatarsal phalangeal joints or of the phalangeal joints following perhaps a crush injury to the toes. And if we look at the injured worker from the posterior view at the push-off phase of gait, in the presence of normal gait, we would see that the arms are at an equal distance from the body. The right elbow is partially flexed, the left elbow is extended, the right hip is slightly laterally rotated, and now the plantar surface of the heel and midfoot are visible, while the forefoot and toes are in contact with the ground or the floor. In the presence of pathologic conditions, we would see, for example, perhaps that the arms could be at an uneven distance from the body. Finally, while the swing phase comprises the lesser portion of the entire gait cycle, approximately 40% of the entire cycle, deviations in swing phase are sometimes even more evident than are deviations found during the stance phase of gait. So let's go over some normal and abnormal findings that we might see in the swing phase of gait. Now again, looking at the right foot from a lateral view, in the presence of normal gait, we would see that the arms are near the midline of the body. The pelvis has a very slight anterior tilt. The right hip joint and right knee joint are both slightly flexed, and the right ankle is in slight dorsiflexion. In the presence of pathologic conditions, you could observe a posterior tilting of the pelvis. You could observe that the right hip and right knee flexion could be exaggerated. You could see that the forefoot is dropped into plantar flexion and that the toes drag on the floor. And take a moment to visualize this in your mind's eye. This is describing the so-called steppage gait, or the equine gait, found in weakness or dysfunction of the anterior tibialis muscle. And there's many different causes of dysfunction of the anterior tibialis muscle. Now, from the anterior view, and again, just viewing the right lower extremity, normal mid-swing phase would be characterized by having the head and trunk vertical. The arms would be at an equal distance from the body. The pelvis has a very slight list to the right. The right hip is in very slight medial rotation, and the right ankle has slight eversion, the purpose of which is to help the toes to clear the ground. Now, in the presence of pathologic conditions, you might observe that the trunk leans to the left, pelvis is lifted on the right side. The right hip is abducted, and the leg may be circumducted in an arc in order to help the leg clear the ground. And the hip is laterally rotated, and the forefoot is dropped into plantar flexion. Now, these are just some examples of many of the possible different types of deviations in gait, and you've likely observed others. And these examples are just given to help you sharpen your interest in the observation of gait in your injured workers. And I recommend an exercise that you can do to sharpen your awareness of gait, and that is to observe gait in the public, out in the public, whether you're at the supermarket, at the mall, at the post office, anywhere where there's large numbers of people is a good opportunity to observe gait. And I recommend that you make this a regular example, make this a regular process, because like the old saying, what you focus on expands. If you start to focus your attention on gait and gait patterns in the public, your awareness of gait disturbances will expand, and you'll start to notice examples all around you of disturbances in normal gait. Now, because each person's gait pattern is unique and is adapted to their own personal physiology and their own personal somatotype, it's impossible to define one single perfect or even quote-unquote normal gait, but deviations from the normal gait in any person usually stick out like a sore thumb once your awareness becomes tuned in to look for it. And once identified in the setting of the qualified medical evaluation, your task then turns to determining the cause of the gait disturbance. So identifying the gait disturbance is the easy part. Sometimes identifying the actual cause of the gait disturbance is slightly more difficult, and we turn our attention to a determination of the cause of the deviation of gait in our next section. So let's now go into some of the causes of deviation of the normal gait. And all of the detail of the prior section on the normal and abnormal findings in gait need not complicate the gait analysis. Might seem a little difficult to assimilate initially, but that should not make the gait analysis more complicated than it needs to be. In order to simplify matters, recall Webster's common sense description of gait. And that is a manner of walking or moving on foot, a sequence of foot movements, such as a walk, trot, pace, or canter, or a manner or rate of movement or progress. So, in order to make things very simple, we simply begin the gait analysis with an observation of the manner. We notice the manner of walking or moving on foot and the manner or the rate of movement or progress. And so we observe the manner in which the injured worker walks and moves. Like we said in the prior section, with normal gait, the head is erect, the shoulders are level, the trunk is vertical, the arms swing reciprocally, and we introduced that term now because we only alluded to it prior. The arms swing reciprocally, and that means that as the right leg comes forward in the swing phase of gait, the left arm comes reciprocally forward. As the left arm goes behind the body in the stance phase of gait, the right arm comes in front of the body. So we have reciprocal arm movements, and the arm movements should be of the same amplitude, and the arm should be at the same distance from the body. The steps are of the same length, and the timing is synchronized. synchronized. That would be a smooth manner. And the body undergoes vertical oscillations that are definite and that have an even tempo. Okay, so that's simple. That's simple. That's a smooth manner. That's an unlabored manner. Therefore, any deviations from the above would qualify as an abnormal gait. You don't have to make things overly complicated. Any deviations from a smooth or unlabored manner would qualify as a gait deviation or a gait disturbance. So once you identify a gait deviation or a gait disturbance, the task then turns to an identification of the cause of the gait disturbance. And there are several different types of causes, or there are several different causes for disturbances of gait. And we'll talk about each of those. Commonly, most common would be pain. Also, we could have muscle weakness that causes deviations of gait. Limitations in joint movement can cause deviations of gait. Incoordination of movement can cause deviations of gait. And then finally, changes in either bone or soft tissues can cause alterations in the gait pattern as well. Let's talk about each of these common causes that we'll see in the context of the qualified medical evaluation. Most commonly, what we're going to see as qualified medical evaluators is going to be pain. Pain. Oh, the pain, right? All injured workers report pain. Well, sharp or frank pain and even lesser pains can cause distortions in gait. And these distortions in gait can run the range from small or subtle deviations in gait to even profound or profoundly labored misalignments or profoundly labored gait movements. Now, these are going to be most evident during the stance phase of gait, the weight-bearing phase of gait, and pain manifests here as a shortened stance phase, with the examinee attempting to get off the painful part. And that makes sense because when you're having pain, no one in their right mind or in the real world would want to exaggerate or exacerbate that pain. So in the presence of pain, there's a shortening of the stance phase in order to get off of that painful part. Now, it's always useful to question the examinee. I used the term earlier to interrogate the examinee about the source of the pain and to confirm that in their own opinion they do indeed have a limp. And in the presence of subtle deviation, the injured worker may give it away, the presence of pain, by a facial expression. In other words, facial expressions may offer some type of a clue to the presence of a problem. Muscle weakness can be a cause of deviation of gait. And muscle weaknesses can be localized or specific weaknesses, such as in the prior example of weakness of the anterior tibialis muscle, or the muscle weakness can be generalized to an entire lower extremity. For example, in the case of a post-surgical knee replacement where the entire lower extremity is painful, inhibited, and weak. And in the presence of muscle weakness, gait deviation is often evident as a widened base of support. It's often evident as deliberate short steps, and often evident as asymmetric or diminished arm swing. And then also you might find difficulty in balance, particularly upon the weak leg. And this is often evidenced also as a shortened stance phase, evidenced by deliberate short steps. And you'll pick this up. It's quite easy to detect when it's present if you're paying attention for it. Limitations of joint motion can be causes of deviation from normal gait. Many times limitations of joint motion can be due to muscle shortening conditions, may also be due to pathologic joint conditions, for example, joint arthritis, may be due to surgical procedures such as the placement of metal implants, metal plates, metal rods, and I have some examples of gait disturbance due to the placement of metal plates and rods coming up here shortly in our PowerPoint presentation at least. For those of you listening to the audio program, I will describe a case history of an injured worker that had the placement of metal plates and rods that ultimately affected his gait. Limitation of joint motion may be due to disuse. Disuse either due to pain, we could also call that favoritism or avoidance. Disuse due to pain. Could be disuse due to having the lower extremity in a cast, such as we would see following a fracture. Now, gait deviations due to limitation of joint motion can usually be seen equally in the stance phase and the swing phases of gait, and you can imagine that in your mind. Imagine the disturbance in gait that might be present in a post-surgical knee replacement procedure, for example, or, for example, an arthroscopic procedure on the neck, on the knee, such as medial meniscectomy or an anterior cruciate ligament reconstruction, for example. Typically, these patients would be fitted with a knee orthosis, the purpose of which is to specifically control the range of motion of the knee. And lacking normal knee flexion and extension, picture in your mind how such a lower extremity would pass through the stance phase of gait. Picture in your mind how it would pass through the swing phase of gait. And you can imagine that, in the presence of a knee that lacks full extension, for example, that would cause deviations in both the swing and the stance phase, and those are easy to picture in your mind. Incoordination of movement can cause deviations from the normal gait, and generally incoordination of movement is due to neurologic disorders. Typically these manifest as distinctive deviations from the normal gait, and even though they're not so easy to characterize, they're generally easy to recognize. For example, you might see a scissor and toe walking gait in spastic cerebral palsy. And here in my own neighborhood in the Sacramento, California region, almost every day on my way to work, I pass a person walking on a sidewalk who is apparently out for their morning walk, but they have spastic cerebral palsy, and I can tell that because of the scissor and toe walking gait. Nonetheless, they're able to walk. This person I see walking every day, and I have seen him for years, but the gait disturbance is quite labored, I might say. Another example would be a festinating gait of Parkinson's syndrome, and we describe that in a little bit more detail in a few moments. Another example would be the hemiparesis gait secondary to, for example, a cerebral vascular accident. This would manifest as a unilateral lower extremity weakness with spasticity in the upper extremity. And the upper extremity is typically held in flexion, with the elbow flexed, the wrist flexed, and the fingers flexed. And the lower extremity is in spastic extension. Now, with the foot and leg in spastic extension, the leg becomes too long. And therefore, in the swing phase of gait, in order to have the leg clear the ground, the gait has to be circumducted to the side in order for the leg to step forward. This type of gait is typically found in lesions of the upper motor neurons, so-called hemiparesis gait. Finally, changes in bone or soft tissue can cause deviations from the normal gait pattern. An obvious example would be an amputation or even bone shortening following a fracture, or bone shortening or lengthening conditions due to congenital malformations. These would lead to a variety of deviations in gait. These would be observable either in the stance phase of gait or in the swing phases of gait, or possibly even in both of the phases of gait. Now, each of these causes of deviation in gait should be confirmed by objective physical examination findings, and not simply be the result of subjective factors such as reports of pain or reports that it feels as if something's going to give way. But there should be objective, bona fide physical examination findings. And that makes sense because, for example, if we're talking about a hemiparesis gait due to a cerebral vascular accident, we're going to see positive objective examination findings of upper extremity and lower extremity spasticity. Those are positive objective findings. Other possible objective examination findings that we could see would be findings of inflammation. Recall the cardinal signs of inflammation, such as redness, heat, swelling, pain, and loss of function. Okay, especially in the presence of pain, we would expect to see some signs of inflammation, especially in the situation of acute pain. We may also see signs of atrophy of the involved lower extremity. That would be a verifiable objective finding. We could see decreased range of motion measurements compared to the unaffected contralateral joint, especially in the presence of post-surgical procedures such as the placement of metal rods, metal implants, or even in the case of post-surgical fibrosis. And in the presence of neurologic conditions, for example, lesion of upper motor neurons, we would see the presence of pathologic reflexes. Now, gait disturbances in the industrial setting are many because, like in the general population, injured workers bring their health history with them to the industrial setting, and as a result, the workplace is comprised of people with a variety of concurrent health conditions and other issues. And combined with industrial injury, pre-existing health conditions can manifest in the gait. And there's several different types of characteristic patterns, and I'd like to go over several of the abnormal named gait signs that you'll run across or that you may be familiar with. And the first one is the antalgic gait, and this is described in the AMA guides. The antalgic gait describes a leaning away from pain. Now, the word antalgia comes from the 18th century Greek word anti-algos, which means basically leaning away from pain. And with pain, the injured worker will be observed to lean away from or to unweight a painful part. For example, in the case of right-sided lower back pain, the injured worker will be observed to lean to the left in order to get away from the pain. So with right-sided lower back pain, the injured worker will lean to the left to anti-algos to get away from the pain. You can observe this simply in the postural examination. You would observe the injured worker to posture to the left. And this might be even exaggerated in the gait in order to get away from the painful right-sided lower back pain. As another example, in the case of a sprain of the lateral talofibular ligaments, severe ankle sprain, the injured worker would be observed to shorten the stance phase on the right foot. In this case, if we're talking about the right foot, would be observed to shorten the stance phase of the right foot in order to get away from or to get off of the pain. And you would see that the stance phase and the swing phases of gait approach a 50-50 time ratio, or even a lesser amount of time spent in the stance phase of gait, depending upon the amount of pain in that injured ankle. The level of pain, therefore, determines the degree of antalgia that you might observe. There is many instances where we will see a broadened base of gait. And a broad base gait is found in many different types of conditions. It's found in infectious conditions, congenital conditions, developmental disorders, traumatic disorders, etc. And this is due to an impairment of the ability to coordinate the movements required for normal walking, because normal walking requires normal motor function and also requires sensory input from the neurologic system in coordination of the motor output programs involved with a normal gait cycle. So, therefore, difficulty with balance and difficulty with coordinating the movements required for normal walking requires the need to widen the base of support in order to provide additional balance. And I'm sure you're familiar with the broad-based gait yourself. In fact, anyone who's gotten up in the middle of the night to use the bathroom is familiar with the broad-based gait. You get up in the middle of the night and the room is dark and the hallway is dark, and you have to make it to the bathroom without turning on the lights. Otherwise, not only will your eyeballs freak out, but if you're married, your spouse will as well. And it's the lack of sensory input through the eyes that reflexively causes the gait to broaden in order to provide balance and prevent lateral reeling. And I remember a recent episode in my own house where I got up in the middle of the night and I was leaving early for appointments, and I was trying to maneuver around the house without disturbing my spouse, and it was dark, and I thought I was going in a straight line, but it turns out I was laterally reeling because even though I was walking with a broad base of support, the lack of visual input through the eyes fouled up my motor patterns, and I crashed into the grandfather clock and caused all the bells and bongs in the grandfather clock to make a lot of noise. So as hard as I was trying to be quiet and unobtrusive, made quite a racket due to this very thing, the lack of proper sensory feedback. And in this case, it was due to the room being dark, but in the presence of neurologic conditions such as peripheral neuropathy in the feet, for example, an inability to feel the feet, that lack of sensory input from the feet causes a difficulty with balance and a difficulty with coordinating movements, and so reflexively there's a broadening of the base of gait in order to compensate for those impairments. There is the Trendelenburg gait. This is also described in the AMA guides, and the Trendelenburg gait was first described in the 19th century by Friedrich Trendelenburg, when he identified this type of a gait pattern in children with congenital dislocation of the hip. Now, Trendelenburg gait is associated with a variety of both juvenile and adult conditions, all of which have the common feature of weakness of the gluteus medius muscle. And it's the gluteus medius muscle on the weight-bearing side. So what you would see to observation, and considering, for example, the right lower extremity coming in contact with the ground, at heel strike on the right side, the pelvis would suddenly drop inferiorly to the left side, to the unaffected side. And if you've ever seen Trendelenburg gait, it's a pronounced deviation in gait, and it's accompanied also by a shortened stance phase on the unaffected side, as the affected side quickly moves back to resume its own stance phase. And so with a Trendelenburg gait, you see gait deviations both in both the stance and the swing phases of both lower extremities. Okay, the steppage gait is also known as the equine gait. This is a named gait sign. Steppage gait is due to weakness of the anterior tibialis muscle, which causes a loss or weakness of ankle dorsiflexion. And what could be some causes of weakness to the anterior tibialis muscle? Well, one thing would be direct trauma to the anterior tibialis muscle itself, perhaps a contusion injury to the front of the leg. Anyone who's ever hit their shin on a door jamb or on a table, coffee table, will know that that direct contusion can cause an instantaneous weakness of the anterior tibialis muscle and make walking interesting. Can also be due to neurologic disorder of the spinal nerve root. Typically we think of the anterior tibialis muscle as being innervated by the L5 nerve root, but also because of multiple innervation and variability, could also be due to a lesion of the L4 nerve root, the S1 nerve root, or possibly even the S2 nerve root, or could be due to damage to the peripheral common peroneal nerve as it passes behind the head of the fibula. And with a steppage gait, what you're going to see is there's an inability to control the ankle through dorsiflexion. Inability to dorsiflex the ankle. As a result of weakened dorsiflexion, you're going to see increased hip and knee flexion in order to bring the foot high enough for the toes to clear the ground. Now, depending upon the level of weakness of the anterior tibialis muscle, the steppage may be slight, very slight, exaggerated flexion of the hip and knee, or it may be very profound in the case of complete paralysis of the anterior tibialis muscle. The steppage may be markedly exaggerated, and that's when it becomes known as the equine gait. And if you've ever seen a person with steppage gait, it's quite a pronounced disturbance. I remember when I first saw it, there was a woman in my gym who came in generally about 10 minutes after I did every day, and she would walk across the foyer of the gym and across a long corridor, and you could see her high steppage gait, and her toes would slap the ground, and it was quite an awkward gait. Anyway, just a note and a word from our sponsor. She responded quite well to chiropractic care, and she later went on to travel to all 7 continents, and so she was able to overcome her gait disorder through chiropractic care. Okay, you may see, for example, also a festinating gait. Festinating gait is found in central nervous system disorders that cause lower extremity hypertonicity. This type of gait is characterized by difficulty in initiating the gait, difficulty getting started, difficulty getting the legs going. But once the gait gets started, the head and trunk get ahead of the base of support, and the steps become increasingly shortened, and they become jerky, and it becomes difficult to stop, and it appears that the examinee is falling forward and that they're constantly trying to get their legs to catch up with the falling forward upper body. And you'll see these and other types of disturbances in gait. And there's many other different named gait signs that we won't really go into here, although you may have heard of these, and you may even see these, although probably not as much in an industrial setting or with your injured workers. Examples would include a hysteric gait, an athetotic gait, perhaps a Charcot gait due to trauma and degenerative change of lower extremity joints, particularly in the foot. And all of these gaits can be easily identified to careful observation because they fit Webster's definition of abnormal movements, of labored manner, of moving forward on foot, of an unbalanced sequence of movements of the foot. And you'll pick these up. And next in this program, I have several videos, and we'll go over those as examples of different types of gait disturbance. And these examples will help highlight some of the concepts and topics that we've discussed up until this point in time.
Just walking normal.
To protect the privacy of the injured worker. And what we're going to do is we're going to show these videos, and I'd like to demonstrate the importance of several of the principles that we've gone through so far, and I'll point those out as they become evident. Okay, so the question that I have for you, here we are, we're about ready to evaluate gait from an anterior view as the injured worker walks 20 yards towards us. So the question that I'm having for you as you watch this videotaping is this an example of normal or abnormal gait? Okay, so we'll begin our video tape here, and I'd just like to have you make a determination as to whether or not this is normal.
Just walking normal.
Well, what we could safely say is if there is a gait disturbance there, whatever it is, it's subtle. And the one thing that stands out perhaps as an abnormal finding would be possibly a right external rotation of the right lower extremity, contributing to a foot flare on the right. Other than that, there are no major gait disturbances that I would report, and I suspect that you would probably state the same. Let me give you a little history on this injured worker. This is a 22-year-old male who had his left leg jammed between a metal pole and the forks on a forklift. and it resulted in a crush of the distal tibia and fibula. This required open reduction and internal fixation with the placement of screws and plates both in the tibia and the fibula. And these are the post-surgical scars. This is the fibula, scar over the fibula that has a plate and screws, and this is the scar over the tibia that had some reconstructive screws in place, and they're still in place, and they were in place at the time of this examination. So that is a history with a different view. Let's see if we can disturbance it's post-surgical. You can see he has a lack of dorsiflexion, which results in a shortened stance phase, especially on push-off phase. See how he gets off it, gets off it, gets off it. And it's interesting. I hope you caught that, doctors. That's he had a slightly shortened stance phase due to a lack of dorsiflexion at the ankle at the push-off phase. What about this case? Tell me, in your opinion, is this normal or abnormal gait? Is there a gait disturbance at all?
And back.
Disturbance here, doctors? Lower extremity rhythm appears fine. How about upper extremities? It's absolute lack of arm swing. Would you agree? There's no arm swing. And notice the contracture of the right upper extremity. There's flexion contracture at the elbow, at the wrist, and at the fingers. And this is an injured worker who has a superimposed early tremor disorder diagnosed as early Parkinson's disease, not yet manifest in gait disturbance of the lower extremity, but manifest as a disturbance in the rhythm of the upper extremity and loss of reciprocal arm swing in the upper extremities. And so the question you might be wondering is, does this qualify for permanent impairment as a gait disturbance? Well, the Parkinson's disease, of course, was non-industrial, but hypothetically, could disturbance in upper extremity function that results in a loss of reciprocal arm swing during gait, could that qualify for permanent impairment? Well, under the strict applications of chapters 13 and chapter 17, probably not correct. But under Alvarez-Guzman 2, I leave that to your imagination and your own judgment as to whether, in your opinion or not, loss of arm swing during normal phases of gait would qualify for permanent impairment or not. Certainly it results in a disturbance of gait because reciprocal arm swing is important. I think it would be safe to say that without reciprocal arm swing, it would certainly make running difficult, if not impossible. It would make walking fast difficult or not impossible. And so I simply introduced this here to stimulate your thinking. And later on we have another example of an upper extremity case. And so we'll refer back to the possibility of analogous impairments to Alvarez-Guzman as relates to the importance of the arms in the normal phases of gait.
Normalmente. Está bien.
Would be subtle at most. Would you agree, doctors? It would be subtle, if at all. Significant gait disturbance here, and when I questioned the injured worker as to whether or not, in his opinion, he felt like he had pain or limp or any kind of compensation for his gait, he denied that, even though he had a serious left knee injury where he had a direct contusion. He fell directly down onto his knee and aggravated some pre-existing degenerative changes and caused new injury to the knee. After a period of time, treatment and healing, the knee recovered most function, and while I found some permanent impairment for the knee, I did not find permanent impairment due to gait disturbance, and he was in agreement with that.
Esto es requerido
frontal thigh, lateral thigh pain, not posterior thigh pain, and no pain below the knee, strictly left thigh pain. Well, safe to say that if there is a gait disturbance there, it would be subtle. There's not a major gait disturbance, but perhaps you could hallucinate that there was a slight shortening of the stance phase or something, perhaps. Whatever it is, it would be slight. Following a lower back lifting, twisting injury. What I found on this is I noted that there was a slight shortening of the stance phase on the left leg. However, when I reviewed this multiple times, over and over, I found that the shortening of the stance phase on the left leg was not consistent with every step. And on some steps it was absent, and on some steps it appeared exaggerated. And based upon the findings of the physical examination and some other historic inconsistencies, I opined that I did not find this to be a credible or consistent gait disturbance, and I did not provide permanent impairment for gait disturbance. This is a young woman with right shoulder and upper extremity injury, and she reports that she cannot hang her arm down to the side, and as a result that when she walks she has to hold on to the lapel of her jacket or put her hand in her pocket so as to avoid strain on tendons and tissues in the shoulder. And based upon physical examination findings, historic findings, medical records findings and later findings of functional capacity evaluation, I found this consistent with the condition of her shoulder, and I opined for a gait disturbance under Alvarez Guzman due to loss of reciprocal arm swing of the upper extremities. So interesting case there. Okay, now let's go into assistive devices. This is an interesting set of topics, and I hope you'll enjoy this discussion. We'll go over some materials here that you'll hear not discussed in other programs or in other writings, and so I'm hopeful that this will be very helpful for you. Assistive devices are described in the AMA Guides Table 17.5, and this is on page 529 if you want to follow along. And this table 17.5 discusses assistive devices that are required in certain lower extremity impairments. And if you're looking at your book, you'll notice that with the exception of 2 instances, all impairments describe dependence. And I emphasize that word dependence on an assistive device for mobility. And for instances of permanent impairment due to gait disturbance, there must be objective findings of pathology, such as those found on imaging studies. And in relation to the lower extremities, imaging studies would include signs of at least moderate and possibly even advanced degenerative changes. Now, those aren't the only possible objective findings of pathology, but those are the ones that are described in Table 17.5. I believe other findings of pathology would qualify, such as post-surgical implantation of metal hardware with resulting scars and loss of joint range of motion. In my opinion, that would also qualify as an objective finding, but that's not found in the descriptions in Table 17.5. Further, the use of an assistive device alone does not necessarily in and of itself qualify for permanent impairment, especially when the assistive device is based largely on subjective factors such as claimed pain or a feeling that the leg or the lower extremity is going to give way. That would be the use of an assistive device based only on subjective factors. There must be positive objective findings to support the need and use for an assistive device. In my opinion, and this is not written anywhere in the guides, in order to qualify for consideration for permanent impairment due to gait disturbance under Section 17.2c of the guides, any assistive device must have a written prescription or must be provided by the primary treating physician or other consulting specialist. Also, the assistive device, in my opinion, must be properly fit for the patient's condition and body habitus, and the patient must be properly instructed on the care and use of the assistive device. And we'll discuss each one of those findings, each one of those requirements, each one of those criteria in just a minute. So, in order to qualify as a medically necessary device, it must be prescribed by the primary treater, must be properly fit for the patient's condition and body type, and the patient must be instructed on its proper use. Okay, and we'll go into those, particularly as relates to canes, in just a minute. Section 17.2c describes the following different types of assistive devices. Goes into canes, discusses crutches, discusses short leg braces, also known as the AFOs, discusses long leg braces, known as the KAFOs, discusses wheelchair, and in my opinion, even though they're not specifically discussed in the AMA guides, Walkers could qualify for permanent impairment if it can be shown that the injured worker is dependent upon a walker for mobility. Now, with the exception of wheelchairs, we'll discuss each one of these assistive devices below. And even though they're not discussed in the AMA guides, we'll also go into a brief discussion about walkers. Okay, so let's talk first here about canes. Canes have a specific function. Canes are intended to assist with balance, mostly, primarily, and secondarily to relieve weight bearing from painful joints. Canes are not intended for full weight bearing. Now, even though you've seen hundreds of canes probably in your life, you probably may not have given much thought to them. I know I never did. But there's four basic parts to a cane. There's the handle of the cane. There's two basic types of handles. We'll go over those in just a moment. There's a collar, and the collar is what connects the handle to the shaft of the cane. Then there's the shaft of the cane. That's the straight part of the cane. And the shaft is generally made of either wood or aluminum or other strong or lightweight material. The tip is also known as the ferrule, and the tip is generally made of rubber and comes in various sizes and shapes. Most of them are usually round. The ones that you're probably most familiar with are just small round coverings that go over the end of the shaft. I recently saw an interesting ferrule, interesting tip, and this is just an example of how what you focus on expands. And as I was preparing this article, I all of a sudden became more aware of canes out in the general public. And I was leaving the gym one day, and there was a guy exiting the gym at the same time I was, and so we went out the door almost simultaneously. And as we got outside on the sidewalk, I noticed his cane, and I said, "Well, look at that cane." And he said, "Yes, indeed, yeah, look at my cane." And I said, "Well, what kind of a rubber tip you got there?" And the rubber tip was notable because it was large. It had a large base. I would say the diameter, the radius of the base was probably 3 inches. And he said, "Well, a friend of his just gave him this rubber tip, and it was brand new." And he said, "Look at what my rubber tip can do." And as he said that, he let go of his cane, and because of this large base rubber tip, the cane stood up by itself. It was stabilized by this large rubber tip. And then he pulled a trick on me and caught me a little bit off guard. As he went to reach for the cane, he apparently inadvertently knocked the cane over. And because I was not expecting this, I reflexively went to retrieve his cane for him so he would not have to bend down and get his cane. And he quickly stopped me, and he said, ah. And so I stood back from the cane, and he demonstrated to me another feature of this large rubber rounded base of his cane. He simply reached his foot over and stepped on this piece of rubber and tilted the cane right back up into his hand. So there's multiple benefits of that rubber tip or ferrule of that cane. And so there's many different types. As far as the handle goes, there's many different types of handles, and there's different custom configurations that you can get. And most commonly, the two basic types of cane handles that you'll see are number one, a rounded handle cane, and these are the most, or I should say the least expensive. Therefore, they're the most common that you'll find. And the second type of cane handle is called a T-handle cane. And you'll see these out in the general public as well. And they come with various different configurations and customizations. And there's many different styles of the T-handle cane. Now, because of its shape and its accommodation to the hand, the T-handle cane is much more comfortable to use than is the rounded handle cane. The rounded handle cane focuses most of the weight onto the pisiform bone of the support hand. And you'll recall that the pisiform bone is a sesamoid bone, just like the patella is a sesamoid bone. It's a sesamoid bone. It's embedded in the tendon of the flexor carpi ulnaris muscle. And because the weight then comes down onto the sesamoid bone, this is not acceptable over time. This is going to be painful to use over time. So when I see a person that has a rounded handle cane, I conclude that because of this drawback, the fact that the weight comes down onto the pisiform bone, this indicates to me that this cane is in limited use because it's simply not comfortable to use over a long period of time. On the other hand, a T-handle cane is more suggestive of full-time use because it is more comfortable, because it does fit the hand better, and because it distributes more of the weight-bearing load over a greater surface area of the hand. Also because T-handle canes are more expensive, and because they can be purchased in personalized and customized design, in my opinion, the presence of a T-handle cane indicates a more committed, more long-term cane user. And so these are a couple of things that I look at when I evaluate the use of canes with injured workers. Now, when evaluating gait in a cane-bearing examinee, there's a few things that we're going to want to take a look at. First of all, we're going to want to see whether or not the cane is properly fit to the injured worker. And so that raises the question, what is the proper fit of a cane? Have you ever thought about that? I never did. I never gave it a second thought. But a cane should be properly fit, and that makes sense. So what is the proper fit of the cane? Well, we'll go over that in just a minute. Next thing you should look at is you should look for the proper use of the cane. And that raises the question, well, what is the proper use of a cane? It makes sense that there probably is a proper use of a cane, but heck, I never thought of that before. What is the proper use of a cane? Well, we'll go over that as well. And then finally, when you evaluate an injured worker who presents with a cane, you're going to want to determine what is their dependence on the cane, because the AMA guides describe varying degrees of dependence on the cane. So there are a few signs of dependence on the cane that you can check that would be objective findings or objective factors, so to speak, that would suggest light, medium, or heavy dependence on the cane. So let's go over these one at a time. You're going to want to check the fit of the cane. So in order to do this, you would have your injured worker stand up straight with their cane at their side. And in this position, the cane in general should come up to about as high as the flexor crease of the wrist, sort of at the radiocarpal joints, at the wrist flexion crease. So the cane should come up to about as high as the wrist when the examinee is standing still and straight. Therefore, when the examinee holds the cane, it will produce a small flexion in the elbow of about 15 to 20 degrees in standing. Now, if the cane is too tall, that's going to place increased angle at the elbow and increased effort at the elbow, and this will be unacceptable for extended use. On the other hand, a cane that's too short is going to put undue effort at the wrist and undue pressure on the hand bones, and of course this won't be tolerated for extended use. And if you identify a poorly fitting cane, you should inquire as to whether or not the primary treating physician actually fit the cane at the time the cane was dispensed. And this will give you a lot of information. If the examinee indicates that the cane was not dispensed nor fit by the primary treating physician or other consulting specialist, in my opinion, this does not qualify as a medically necessary device, at least under the workers' compensation claim. So proper fit of the cane tells us a lot. In fact, if the cane was simply given by the uncle or a relative or a friend, or the cane was picked up at the pharmacy on a self-procured basis, in my opinion, many times because the injured worker has not been properly trained or fit for the device, this would not qualify as a medically necessary device, at least under the workers' compensation claim. And that's just my opinion. You're going to want to check for the proper use of the cane. And so, what is proper use of a cane? Well, that's interesting. That's interesting to consider. Proper use of a cane involves use of the cane in the hand opposite to the side of the pain, with a shift of weight to the cane and therefore off the affected limb. Recall that with normal gait, the movement of the arms is that the arms move reciprocally with the legs. As the left leg comes forward to the stance phase of gait, there's reciprocal forward swing of the right arm. So in an effort to relieve weight bearing from, for example, a painful left lower extremity, weight is shifted to the cane in the right hand as the right hand comes forward in reciprocal arm swing. To carry the cane in the left hand to relieve weight bearing from the left lower extremity would be improper use of the cane. In cases where improper use of the cane is identified, what you would want to do is you would ask the injured worker as to whether or not the primary treating physician demonstrated the proper use of the cane at the time that the cane was dispensed. Again, in my opinion, if the cane was not dispensed by the primary treating physician, it does not qualify as a medically necessary device, at least under the workers' compensation claim. And one of the ways that you can determine this is by checking for proper use. Sometimes you'll see the cane used in the wrong hand, and that's a tip-off that the cane was, well, it's a tip-off at least that the injured worker was not instructed in the proper use of the cane, and it might therefore indicate that the cane was obtained on a self-procured basis, in which case it's actually not a medically necessary device. Sometimes you'll have a chance to observe the examinee using the cane going up and down stairs. So proper use of the cane when ascending stairs, you'll see that the examinee should step first with the unaffected leg. This is going upstairs now. So the first step is made with the unaffected leg, or the good leg. In this case, we're talking about the right leg. So the injured worker examinee would place the right foot on the next stair up from where they are. Then what they would do is they would bring the cane and the affected leg up by straightening the good leg at the knee, so that all weight bearing is done by the good leg, or the unaffected leg. So as the unaffected leg reaches up to the next step, the weight is borne between the affected leg on the upper step and the cane on the lower step, thereby relieving the affected leg. When it's done in this way, all weight bearing is borne by the unaffected leg, and the affected leg simply trails along for the ride with very little weight bearing load placed upon it. Now, if you identify improper technique in going up and down stairs, that would indicate minimal to no impairment of the supposed or claimed affected leg, in my opinion. When descending stairs or going downstairs, a similar but opposite procedure is used. The examinee should step down first, this time with the affected leg. This is an interesting little nuance. When going upstairs, you step first with the unaffected leg. When descending stairs, the examinee should step down first with the affected leg and the cane at the same time. And then they lower themselves slowly by bending the unaffected leg's knee until the cane and the affected leg's foot are in firm contact with the next stair down. Then you bring the unaffected leg down to the same stair. So that makes sense. As you step off of the stair to go down to the next stair, you step off with the unaffected leg with the affected leg, because the affected leg certainly would not have the power to control a large eccentric lowering contraction with all body weight plus the acceleration due to gravity. That must be done by the good or unaffected leg. So it's the unaffected leg that does all the muscular and weight-bearing effort. The affected leg simply reaches down to the next stair and lands on the next stair as it's placed there by the lowering effect of the good or unaffected side. You might also observe that the examinee steps down the stairs in a sideways fashion. This helps to recruit the large anti-gravity hamstring and buttocks muscles. Now, when this is done properly, all weight-bearing effort is borne by the unaffected leg, and the affected leg simply acts as a balance support. Done improperly, a large eccentric load to the gastrocnemius, the quadriceps, and the hamstring/gluteus muscles would indicate, at least in my opinion, absent impairment of the affected leg, or at the most, minimal impairment. Because if you can go downstairs with the affected or claimed affected leg, with that leg supporting a large eccentric load, that would indicate to me that any impairment of that extremity is minimal at most. Finally, you're going to want to check the dependence on the cane, and we do that by examining the cane. And basically, you're going to want to check how beat up the cane looks, how much wear and tear it looks like the cane is getting. For example, the shaft of the cane might have scrapes or scratches or dents, or in the case of a wooden shaft, might have some abrasions or scars on it to indicate that it's getting quite a bit of long-term use. The rubber tip on the bottom of the cane gives an indication also of its workload. A fresh, symmetric rubber tip would indicate very little use. Discolored and or a worn rubber tip would indicate more use. So you're going to want to examine the cane, and you do that by asking the injured worker to allow you to check the cane. And you examine it, and you look for wear patterns around the handle, oil deposits from the palm of the hand onto the handle of the cane. You would check the shaft for wear and tear, and you would also check the rubber tip for signs of long-term use. And in order to demonstrate some of these principles in use, we have a case study here that involves a 32-year-old male with claimed right radiculopathy. And remember that discussing
Bien.
First check the assistive device for proper fit, then for proper use, and then finally we want to check the dependence on the cane. And so I have here a videotape from my files. This is an actual case from my files that involves a case of claimed right radiculopathy. And as you look at this injured worker, his right would be to your viewing left. And so we went outside to videotape the gait, and I had him walk 20 yards toward me down this long sidewalk. And just as you see this still photo here in front of you, let's take a look at the fit of the cane. And recall we said that with the arm hanging down to the side, the top of the cane should come to the flexor wrist crease. And you can see that in this case, if the cane was standing vertically upright at its maximum height and the elbow was extended to its maximum length, the cane would probably come up to about the lower 1/3 of the forearm, which is set too high. Also, you can note that the angle of the elbow is greater than 15 to 20 degrees, thereby placing large load onto the triceps, which is going to be unacceptable over time. So, might not be an example of proper fit of the cane. Let's then take a look at whether or not, in your opinion, this qualifies as proper use of the cane.
Bien.
What did you think? Well, this is a 32-year-old with claimed right-sided radiculopathy. We would expect that the cane would be placed in the opposite hand to correlate with the reciprocal arm swing. You can see that the left arm is forward while the right leg is backwards, so he is using reciprocal arm swing, but the cane is being used in the improper hand. And so, in my opinion, I inquired as to whether or not he was instructed in the proper use of this cane, and he told me that the cane was simply given to him by his uncle, and I opined that this was not a medically necessary device. So we found that there was improper fit, and the cane was on the wrong side for a claimed right radiculopathy. This case later closed and settled by compromise and release, and permanent impairment, at least related to positive objective findings, was minimal at most. In addition to canes, you'll also see other types of assistive devices, although less common in the industrial setting. Occasionally you see a quadrupod cane, you might see occasionally a pickup frame walker, and you might occasionally see a wheelie frame walker, so we'll talk about those briefly. Quadrupod cane has a large base of support to provide added stability, and you'll notice that this cane here can stand up by itself. And the fact that it can stand up by itself means that it can pretty much stand its user up very stably as well. Problem with these is sometimes they're a little bit heavier than your standard single point cane. This shows a very large base, and you'll see these with varying sizes of bases. This one here is a large one, probably one of the largest that I've seen. Occasionally you'll see walkers. On the left of this diagram is a pickup frame walker, and with a pickup frame walker, the injured worker will grab a hold of the handles here and use the handles to support or unweight their lower extremities or perhaps their spine, and then they advance the pickup frame walker in front of them, set it down on the ground, and then scoot themselves up to meet the walker, and then that process repeated step by step. Occasionally you'll see a wheelie frame walker. Generally the ones I've seen have a yellow tennis ball on these back legs here to minimize scuffing and noise as this thing moves along. Wheelie frame walker works basically the same as a pickup frame walker, with the exception that there's wheels here on the front. That eliminates the need for this walker to be actually picked up and set down every time a step is taken, so makes them a little bit easier to use. Depending upon the impairment and the need for support, there are different types of walkers. This is an orthopedic walker that obviously is much more substantial and relieves a greater weight-bearing load from the lower extremities and the spine. Over here I call this the Indy 500 walker. You see these frequently in malls, and these are in popular use out in the public nowadays. It includes additional features such as a seat here for sitting and a basket here for placing personal items and shopping items and what have you. Crutches are a little bit different than canes because crutches involve 2 points of contact with the user. Like the cane, the first point of contact is at the hand, but crutches have a second point of contact either at the forearm or at the armpit, depending upon what type of crutch we're talking about. And because they offer 2 points of contact, this provides added weight-bearing relief over that offered by a cane. And remember that the primary use of a cane is to offer added stability and support, but not to be a primary source of weight-bearing relief. The most common type of crutch in popular use is the axillary crutch. And the purpose of an axillary crutch is to be able to provide weight-bearing relief, and these crutches can provide even complete weight-bearing relief. And if you've ever sprained your ankle or had a knee injury and you've used these crutches, you know that they can provide complete weight-bearing relief from that lower extremity. Now, axillary crutches have 3 important features. They have an axillary pad that covers the top of the crutch here. They have a hand pad here, which should be made of foam or some soft material. And then they have a rubber tip right here. Always inspect the axillary pads on the crutches. If you see crutches without an axillary pad, that would suggest that those crutches are used for those crutches are in limited use or are used only for short durations of time, because extended use of an axillary crutch without the pad is not acceptable for long-term use. Axillary pads are necessary to prevent compression on the radial nerve, which is common with long-term use of this type of crutch. Forearm crutches are another type of crutch. And forearm crutches can be used either singly or doubly. They have a cuff here at the top which goes around the forearm. Or other types of forearm crutches would have here a platform upon which the forearm rests. And these are good for weight-bearing relief, and they're very easy to use, and makes it easy to get the arm in and out of here quickly and easily. And acts similarly to a cane, because there's really the major weight-bearing relief comes here at the wrist. You can see that these are adjustable, and you would want to check the forearm crutch's tip for signs of wear and use. Another interesting type of crutch is known as the underarm strutter, and these are crutches that have an articulating base, has a large base for added support and stability, and allow you to move across the base smoothly. And marketers claim that they allow for an improved walking gait and reduce the risk of damage to the radial nerve so common with standard axillary crutches. This is an example of a platform crutch. These are more rare, but are used by those that have weak upper extremities, such as people with advanced arthritis or other conditions. The forearm rests here across this horizontal platform, and the hand rests on a grip here. You can see that this has a quadrupod base for added support and stability. There are rubber tips here that soften the blow or absorb force upon impact, and these are adjustable and should be properly adjusted, and you should check on that. I don't have a diagram of leg support crutches, but leg support crutches are another type of crutch used in certain types of lower extremity injuries, generally injuries below the knee. For example, ankle surgery procedures, foot surgery procedures, fractures of the tibia or fibula. And leg support crutches, what they do is they strap the affected leg into a support frame that simultaneously holds the lower leg clear of the ground. So generally it's bent at the knee and it holds the lower limb clear of the ground. It relieves weight bearing from the affected lower leg and transfers the load from the ground to the user's knee or thigh. And that's has some advantage because it still provides or still allows for some weight bearing to be applied to that lower extremity. Even though the lower leg itself is relieved of weight bearing, some weight bearing goes to the upper thigh and thereby reduces atrophy that can be common with total leg immobilization. These are generally only applicable for injuries below the knee. The AMA guides also discuss the use of short and long leg braces, and this is an example here of a short leg brace, also known as an ankle foot orthosis. This is a brace that's designed to help control motion at the ankle joint. It also offers support to the foot. Examples where this might be used would be in cases of a severe ankle sprain. This brace would give medial and lateral stability to stabilize an ankle sprain. Might be used in cases of drop foot or those cases of steppage gait to assist with gait, where there's lumbar spine radiculopathy. Generally we think of that as L5, or peripheral nerve injury to the peroneal nerve. Also can be used in cases of ankle and or foot arthritis, and there's several different types of those. This is an example of a long leg brace, also known as a knee ankle foot orthosis, and this of course offers greater stability that covers multiple joints here, crossing the knee, crossing the ankle, and into the foot. These are commonly prescribed for muscle weaknesses or muscle paralysis conditions due to various types of neurologic disorders, most common of which that we would see in the industrial setting would involve spinal cord injury. And finally, doctors, we're going to conclude this program, and we've talked about a lot of things. We've talked about the phases of normal and abnormal gait. We talked about the gait cycle, and we broke that down into several sub-phases. We've talked about the need for assistive devices, and I just want to summarize this program by putting the gait evaluation into its proper context. The AMA guides allow for permanent impairment ratings for those cases where there's documentable and objective physical finding of a disturbance in the normal gait pattern. And it's important that we properly identify any gait disturbance and properly characterize it and rate it properly. And so the material in this program has been designed to help with that. I just want to conclude by saying that observation of gait of injured workers tells us a lot. And I want to emphasize this point by giving you an example. Let's say you have an injured worker who you meet in the waiting room, as I've recommended. And you invite the injured worker back to the examination room, and he rises from his chair normally, he stands normally, and he walks completely normally. What can you conclude? What can you conclude? Well, you can conclude that probably the motor system is completely intact. If he's able to stand and walk normally, the motor system is completely intact, at least from a neurologic perspective. Well, if the motor system is intact, then the sensory system is intact as well, because motor output commands are dependent upon sensory input. So if the motor output commands are normal and functional, you can conclude that sensory systems are intact as well. Well, if the examinee follows all your commands, all your instructions, and he follows you and he seems to understand, and there's no confusion and there's no hesitancy, then you can conclude that the mental state and the sensorium are intact. So therefore, with the combination of the motor system functioning properly, the sensory system functioning properly, and mental status functioning properly, you can conclude that the entire nervous system is intact. So what would you expect then in the physical examination findings? Well, this would allow you to expect normal neurologic findings on the physical exam. And any findings, either subjective or objective, that deviate or contradict the findings or your observations of a normal gait, that would require additional investigation, correct? That would require additional investigation, because that would be a contradiction to your normal findings. On the other hand, significant positive findings for disturbance of the normal gait pattern would draw concern to issues related to permanent impairment. And it could be that there is a finding of objective gait disturbance that would qualify for permanent impairment. And the purpose of this article is to bring attention to what a normal gait pattern is, and therefore with that knowledge to help you identify the causes of deviations or disturbances in gait in the normal pattern of gait, and to provide the appropriate permanent impairment rating for your examinee. In the presence of an observed disturbance in gait, really it comes down to a simple matter of identifying the appropriate level of permanent impairment. A dichotomy opens up and separates gait disturbance into those that require an assistive device and those that do not require an assistive device. And in those cases that do require an assistive device, those are easy to classify, and those are clearly spelled out in the tables and charts. Those that do not require an assistive device demand an observation of the gait through a formal gait analysis, and I've laid out a procedure that will allow you to efficiently and effectively do an objective gait analysis, including a videotaping recording for your archives of that particular gait disturbance. And finally, we finished up this program with a discussion on assistive devices. And even though this is not an exhaustive discussion, we do go into detail regarding assistive devices, at least as far as they're mentioned in the AMA guides. and I've given you some clinical indications that will help you determine the legitimate and objective need for assistive devices, and I've given you some indications where the use of an assistive device may be based upon subjective factors only. So doctors, it's my hope that you enjoyed this program and that this program will be helpful for you. At this time, please complete the enclosed 10-question examination. Circle the correct answer, please, and then fax or email the entire examination form to me. Upon successful completion with a 70% score or better, we will immediately fax or email your certificate of completion, which for the audio and PowerPoint presentation programs both qualify for 3 hours of QME continuing education credit. On behalf of easyqmece.com, I invite you to visit our website early and often as our programs are rapidly expanding. I look forward to being with you in the future for your continuing education needs. This is Dr. Perry Carpenter, wishing you the best in life and in your career, and I look forward to being with you soon. Thank you very much.